Organisational change was not our motivator. It was not the reason why we embarked on this journey. Our objective was about improving services to Mrs. Smith, and that the organisational change came out of that work and was a result of the work that we were doing. And I think that that's some of the challenges that we have at the moment with all of the legislation and the guidance and the white paper about all of this organisational change, because we fundamentally believe that it's about doing the right thing for the people rather than thinking about the organisational change. Because if people are thinking about the organisational change, you tend to forget, or your focus is not necessarily on continuing to do the right thing. We created 5 local zone teams, as we call them, zones here in the Bay, and they were focused around the populations for the GP practices. So when anybody contacted Torbay Care Trust, the first question they were asked is, who is your GP? And then dependent on who their GP was, that particular zone would support them. And what we found really quite powerful is there were lots of, we called them handoffs, but lots of people saying, well, that's not us, that's somebody else, so it's not our responsibility, that's health, or it's not ours, it's housing. But by creating the zones and creating teams that supported a local population, the buck stopped with those people in those zone teams. If someone lived in Brixham, it was the Brixham's zone's responsibility to find the solutions and support Mrs. Smith in Brixham. It wasn't going to happen anywhere else, so it brought clarity to the situation. People still talk about Mrs. Smith, and when we're trying to implement something or we're trying to convey a message, we use Mrs. Smith to do that. And we recently had an event where we had lots of professionals. It was over 100 people having an away day, and we said, how many people know Mrs. Smith? Everybody put their hands up, and so this became something that Torbay was known for. But what it did is everybody in our organisation knew what we were trying to achieve. So as simple as it is, everybody from the Director of Finance to the person that worked at the community hospital or somebody that worked in one of the zones, they knew what our business was about and we knew what we were trying to achieve. And I think that's really the message that I'd want you to go away today, that you understand from us. It was about providing the right care at the right time by the right person. Teams that we have. So these are the teams that are locality-based teams, which we call zones. Each of the zones are managed by a zone manager, a general manager. So our structure is general management with professional leadership. And we've always been very, very clear that the manager, ultimately the manager is responsible, and the advice and information to support the general manager, but the general manager is the manager who manages the budget, manages the team, manages the resources, but the clinicians, which are managed on this side, I still manage them all, but the director, the assistant director of professional practice works to me, and she manages the head of social work, head of OT, head of physio and head of nursing, and they provide clinical supervision across all of the zones to all of the social workers in each. So they have forums for social work, forums for OT, forums for physio and OT. Assessment, rapid response times to prevent people going into hospital, keep them at home, don't let them get institutionalised or demobilised, keep them mobile, develop a package of care, a programme of care that could maintain their mobility. And for 2 years we invested nearly £1 million each year into OTs, physios, nurses, coordinators, very important function, to prevent people going into hospital, because as you know, the most costly way to provide care is beds. And for us, we wanted to move that right out into the community. So we've now invested in community intermediate care services. We've 7 days a week, we're able to rapidly respond, prevent escalation, and often we're now much more working in the preventative field. You know, if a nurse goes in today and sees somebody that has deteriorated, maybe self-neglecting, perhaps she's not eating, that would have resulted probably in a referral. Don't know when that person would have been assessed or indeed received services. A nurse can come back this morning saying, I'm really worried about Mrs. Smith. She'll talk to a health and social care coordinator and a package of care can go in this afternoon based on that nurse's assessment. A nurse had put somebody, say the same person as a level 2 because he was a diabetic. But actually, once he had his insulin injection once a month, or I can't remember how often he was getting his insulin, but anyway, she had to give him in an injection. He was fine, so he was quite stable, so he was in level 2. But the social worker had him in level 1 because he had an alcohol problem. He was an alcohol abuser. He was drunk most of the time. What the nurse didn't know, that because she did his insulin injection first thing in the mornings, she never knew he had a drink problem. And so I just sort of give you an example, that was that by sharing the caseloads, we were able to learn a lot about people's caseloads. And what that did also, it started to break down the barriers between the professionals. Sure whether that is relevant now. What we have done, you will see there about acute beds, which you may be interested in. In 1999 we had 750 acute beds. In 2008-9 we had 528, and we've now gone down to something like 450 now. So because we are able to maintain people at home and maintain their independence, even though our demographics are doing this, we are able to reduce our acute beds because we're maximising those beds and utilising all of the beds in the system. So that's quite an important message.
So where did the beds go?
Where did the beds go? We just closed them.
Just close them?
Yes.
Oh.
So you don't even transform them, say, to
Nope.
community or to intermediate care beds?
No, I've just closed them. About June of this year we had a 20-bedded intermediate care bedded unit, which I provided. Quite high cost because obviously working in the NHS we're not cheap, we're not as cost effective. And so what we were finding was that when we did our bed audit, the bed audit I talked to you about, some of those people could have been treated at home with intermediate care, didn't need a residential bed. The other context to tell you is that because in Torbay we have a large proportion of residential and nursing home beds.
Okay.
And what we do now is if we need a bed, we will spot purchase it from the independent sector, much more cost effective, and our therapists support those beds. We only supported 105 people for the year, cost us £1.2 million to do so, and the lengths of stay were quite long. So I think we felt that actually we could if we need a spot purchase bed, we'll buy it in the independent sector, we'll close the beds, and some of those people can be cared for at home, which they can. And we've closed that 20-bedded unit without any noise in the system at all. So, you know, we've saved a significant amount of money by doing so. So we have found, the other thing that we've had in Torbay was that because there wasn't a lot else in the community, lots of people were going into residential care. Historically, over the previous years, and so because there wasn't any extra care housing or there wasn't any intermediate care, people were going into hospital, staying there too long, becoming institutionalised, and then going into residential care and then not coming back out. And what we've done in addition to this you will see here, since February 06, we've reduced our residential nursing home beds from 1,298 per week to 811, and we're down to 600 now.
So you're saying that you have no demand pressure for nursing home beds?
But the most important thing is that coordinator I told you about who's on the ward. So she will be looking, what did Mrs. Smith have before she came in? Can that be picked up on her day of discharge when they know that she's going to be discharged? Or does she need to arrange something? Does she need to arrange the transport? Does she need to arrange the medication? And when the teams on the ward, you know, with the doctors and the nurses, have the multidisciplinary team that says Mrs. Smith is ready to be discharged tomorrow, then that health and social care coordinator on the ward will arrange for Mrs. Smith to go home. Now, if she needs anything additional, piece of equipment, then she will liaise, make a call with the zone team or the equipment store to arrange for that equipment to be there, whatever it might be. For 2 weeks, the hospital team are responsible for Mrs. Smith, still responsible for Mrs. Smith. So if there is anything ongoing within 2 weeks, it's still managed by the hospital team, which is our team, but they're on the ward. The coordinator,
the house.
yes. After that 2 weeks, it then becomes the responsibility of the zone, and the zone picks it up. Does that make sense?
Very good.
So there is a zone team and there's a hospital team.
There's a hospital team that are based in the hospital, working in the hospital.
And they're
a
part of...
coordinator on the ward.
I see.
The hospital team are made up of coordinators, social workers, and community care workers. And so basically their role is to assess Mrs. Smith and make sure that whatever she needs to have to discharge her from hospital happens. Well, you've created the capacity for someone to do the right thing, whereas sometimes, and this isn't a criticism, but sometimes when they're on the ward, the nurses and the doctors get waylaid with other patients, and you know, for whatever reason it might not happen. What we've done is said, this is important, we're going to put that resource in, and then it will happen because it's their responsibility to make it happen. The consultants and the doctors on the ward think that the coordinator is great. They just tell them what needs to happen and it happens. The nurses on the ward who used to do a lot of this, because the nurses used to do the assessments, used to do the paperwork, used to do the transport, used to do the prescriptions, collect the medication, coordinate with the families. They still do talk to the families, obviously, but they've got someone who has to do it.